Today we are going to study rheumatoid arthritis. Arthritis is the disease of the joints, or arthritis is inflammation of the joints. So rheumatoid arthritis is a special type of arthritis. Rheumatoid arthritis is a chronic inflammatory autoimmune disease. So it is an autoimmune disease which is chronic, which is long term, and which is having inflammation in it. So chronic inflammatory autoimmune disease which is of unknown etiology and is characterized by symmetric peripheral polyarthritis. Symmetric means the disease is present in both sides of the body. That means if right finger is affected, then left finger is also affected. So it is symmetric. And second, it is peripheral. It is present mostly in the peripheries, in the hands, in the elbow, or in the peripheral skeleton. This rheumatoid arthritis, since it is a chronic disease, it ultimately causes joint damage and physical disability. The person becomes disabled. It is a systemic disease, and it also has extra articular manifestations. Example, subcutaneous nodules, that is nodules below the skin, fatigue, lung involvement. It causes various pleural effusions, pericarditis, inflammation of the pericardial membrane, neuropathies. It causes vasculitis, the troubles in the vascular system, the hematological abnormalities, the blood troubles, for example anemia. Right, this rheumatoid arthritis is mostly found in females and in between the age group of 25 to 55 years. After 55 years, the chances of getting an RA are very less. So 50% of the cases are associated with a special type of gene present in them, which is HLA-DR1B gene. So what is the pathogenesis in rheumatoid arthritis? So we know that rheumatoid arthritis, the arthritis is inflammation of the joints. So the inflammation of the joints is going to happen. So the most important structure in the joints which is having the pathogenesis in RA is synovial membrane. So this is a joint. You can see these are two bones. For example, let us say this is a knee joint. So this joint, these two bones, they are covered from all the sides by a joint capsule. A capsule kind of structure is enclosing these two bones from all the sides. This you can see is the joint capsule, and the inner lining of this joint capsule is the synovial membrane, which is formed from synoviocytes, which secretes the synovial fluid, right, from the blood. The transfiltrate is called as the synovial fluid, which lubricates the joints. And also these two bones are covered by all the major joints are covered by the articular cartilage. This articular cartilage, it is like a cushion over the bone, so that the two bones, when they move on to each other, they do not produces friction, or they do not rub against each other. So in order to reduce the friction, we have articular cartilage and we have synovial fluid inside the joint capsule. So this synovial membrane becomes inflamed, right? Because of the autoimmune process, this synovial membrane becomes inflamed. So the most important pathological hallmark is synovial membrane inflammation, right? Also the articular cartilage becomes destroyed. The articular cartilage destruction happens, that leads to the thinning of articular cartilage, and lastly the bone starts to erode. So the cartilage loss, the bone loss, and the synovial membrane inflammation are the three major steps or three major processes in the pathogenesis of RA. So this synovial membrane hyperplasia, because of the synovial membrane inflammation, it undergoes synovial membrane proliferation. The synovial lining hyperplasia causes the formation of pannus. The synovial membrane starts proliferating, and ultimately it is called as pannus. So pannus is a thickened cellular membrane which contains two types of cells mostly. Number one, fibroblasts, which are like synoviocytes, and second, the granulation reactive fibrovascular tissue, which basically invades the cartilage and destroys it, and also it causes the bone destruction as well. So the inflammation is caused because of the 6 main type of inflammatory cells, which are T cells, B cells, plasma cells, dendritic, mast cells, and granulocytes. and the destruction of the bone is mediated by osteoclast cell, which are bone deforming cell or bone destroying cells, right? So three types of pathologies happen in RA. Number one, synovial membrane hyperproliferation, right, synovitis. Second, the cartilage destruction, this cartilage becomes destroyed. And number third, the bone also becomes destroyed, so bone erosions also start. This ultimately leads to joint deformity. So some of the genetic factors, like the presence of HLA-DRB1 genes, some environmental factors, for example smoking, and some immunologic factors. The antigen presenting cells, they start or the proteins of the body itself, they start acting as antigens, and in response to those antigens, there is the production of certain antibodies which starts attacking the synovial membrane, causing inflammation, and the inflammation of the synovial membrane further causes the formation of pannus, destruction of bone, and destruction of cartilage. So the loss of self-tolerance because of these factors, certain immunologic factors, certain environmental factors, certain genetic factors, this leads to the loss of self-tolerance. We know what is self-tolerance. Because of the self-tolerance, the body tissues, they do not attack its own body tissues, but when this self-tolerance is lost, then it leads to the stimulation of helper T cells, because helper T cells are stimulated by the antigens, which are basically the cellular proteins of one's body. The cellular proteins start activating the T helper cells, and these activated T helper cells mostly causes these three processes. Number one, it stimulates the macrophages to release most important inflammatory mediators, which are IL-1 and TNF, interleukin-1 and tumor necrosis factor. Second, this helper T cells, they stimulates osteoclast formation, and this osteoclast, they start the bone destruction. And number three, these helper T cells activates the B cells to produce certain autoantibodies, which further causes the more destruction. And the most important antibodies production are rheumatoid factor and anti-CCP. This IL-1 and TNF, right, the macrophages which releases these, they are very dangerous. These inflammatory mediators are very dangerous. They causes, number one, synovial membrane proliferation. The synoviocytes, they become proliferated, and there is formation of pannus inside the joint capsule. And number two, there are production of the prostaglandins, which causes pain and inflammation inside the joint. And second, the metalloproteinases, matrix metalloproteinases, MMP enzymes are released, which causes cartilage destruction. So ultimately the destruction of joints happens, and it leads to disability. Chronically it leads to disability. So the clinical feature most important is early morning joint stiffness. The patient complains of joint stiffness. The joints will not be able to move normally in the morning, especially for 1 hour, and after 1 hour the joint stiffness will slowly go away. Second, the most commonly involved joints in rheumatoid arthritis for pain and stiffness are small joints of the hands and feet, especially the hands, the fingers, they are mostly involved. And number three, the joint involvement is mostly polyarticular or oligoarticular. That means oligo means more than 3, more than 4 joints. Polyarticular means more than 5 joints. They are generally involved, and they are mostly in the symmetrical distribution. That means both the hands or both the feet, they are involved. If right finger is involved, then left finger is also involved. If right middle finger is involved, then left middle finger is involved, like that. Rheumatoid nodules are seen on extensor surfaces, right? These are nodule-like structures which are composed of lymphocytes. Then constitutional symptoms, they might be present because of the inflammation, fever, weight loss, fatigue, malaise, depression. So morning joint stiffness greater than 1 hour, symmetrical arthritis of wrist, right? Mostly it is present in the wrist or metacarpophalangeal joints or proximal interphalangeal joints. These are the most common joints involved, right? It is mostly present in the fashion of in more than 4 joints, in 4 joints or more than 5 joints, and they are symmetrical. The distribution is symmetrical. So you can see here this joint here is the metacarpophalangeal joint. These are metacarpal bones, and these are phalanges, so metacarpophalangeal joint. So this joint is metacarpophalangeal joint. And the next joint to it is proximal interphalangeal joint. Proximal means pass. P stands, let us say P stands for pass. So this is closer to the body, right? So pass, proximal interphalangeal joint. This is dur, right? Dur, away from the body. So this is distal interphalangeal joint. So this is DIP, D, let us say D stands for dur, DIP, and this is PIP, proximal interphalangeal. So once again, MCP, PIP, and DIP. So deformities are common in chronically. So first deformity is trigger finger. You can see because of the flexor tendon tenosynovitis, because of the tendon and synovial membrane inflammation of this finger, it leads to the trigger finger. This ring finger becomes like trigger. Then second is ulnar deviation. The hands, they deviate towards the ulnar side. Similarly, the radial deviation is also found, but very less common is ulnar deviation. The hands turns to the ulnar side. Second is swan neck deformity. In swan neck deformity, there is the proximal interphalangeal joint is hyperextended. Generally, the proximal interphalangeal joint is straight. This finger should be straight from here, but it is hyperextended downwards, and the distal interphalangeal joint is flexed. This first joint is flexed. So flexion of the DIP and hyperextension of the PIP is swan neck deformity, and it stays like this. The person cannot make his finger in any other flexion or extension state. So this leads to the deformity. Person will not be able to hold things properly. Second is Bottonier's deformity. And then in this Bottonier's deformity, the proximal interphalangeal joint is flexed, right? Sorry, the proximal interphalangeal joint is flexed. You can see this is flexed, whereas the distal interphalangeal joint, right, this distal interphalangeal joint and distal phalanx is hyperextended. So flexion of PIP and hyperextension of DIP. Similarly, we have Z-line deformity. The thumb becomes like Z. Extra-articular manifestations, we know that this is a systemic disease, rheumatoid arthritis, so it leads to the other system problems also, like neurological, cervical myelopathies, the compression of the cervical bones, because of the destruction of the cervical bones, it leads to the compression of the spinal cord, which leads to cervical myelopathies. Hematologic diseases like anemia of chronic disease or anemia of inflammation. Nowadays it is called as anemia of inflammation. Splenomegaly, neutropenia, right? Lymphoma, leukemia, the GI vasculitis, right? Blood vessels, they become inflamed. Then osteoporosis, bone endocrine hypoandrogenism, that means the glands, they reduce, so it leads to the reduced production of the testosterone. Then skin, rheumatoid nodules or purpura, specific skin conditions. Then in eye, leads to the inflammation of the sclera, episcleritis, scleritis. Oral, xerostomia, dryness, periodontitis, right, inflammation of the gums. Then pulmonary, pleural effusions, cardiac pericarditis, renal nephropathies. So it affects almost all the systems chronically. Then how do we classify, or how do we identify, or how do we categorize the rheumatoid arthritis? So the American College of Rheumatology, they have given this classification, which is followed throughout the world. So it has 4 ABCD, 4 patterns. Number 1, joint involvement. If one large joint, because this rheumatoid arthritis is a disease of small joint which are symmetrical, having symmetrical involvement. So small joints, if they are involved, then it is 1 to 3 if it is small joints, 2, 4 to 10, 3, and greater than 10, 5. If large joint, no score, and later we will add this score. Second is serological testing, the blood testing. If blood contains the autoantibodies, which are rheumatoid factor and ACPA, we will talk about this ACPA. So if they are negative, 0. If they are low positive, that means their values are less, right, above the normal, right, but less. For example, rheumatoid factor, the normal values are I think 18. So if they are like 20, 25, So that is low positive. High positive are like 105, 205, like that. So they are high positive. So high positive is having more score, low positive is having less score. This rheumatoid factor is an antibody which are produced in rheumatoid arthritis. Third is acute phase reactants, which are the markers of the inflammation. So CRP, C-reactive protein, and ESR, if they are raised abnormal, then the score is given 1. And duration of the symptom, if the pain is greater than 6 weeks, then the score is 1. If we add all these scores and the score is greater than or more, equal to 6 or more than 6, then it is a definite case of rheumatoid arthritis. Investigations: anemia, because it is an inflammatory disease, so it will lead to the anemia of inflammation. AI, serum iron levels will be low, whereas serum ferritin levels will be normal or raised. ESR, CRP, they are abnormal, they are abnormally raised. Rheumatoid factor is present, but only in 70% of the cases. In 30% of the cases, patient will be affected with rheumatoid arthritis, but they will not be having rheumatoid factor in them, right? And also this rheumatoid factor is having a prognostic value. That means the more the rheumatoid factor is, there are more chances of deformity, more chances of severe disease progression. Second is ACPA, anti-citrullinated cyclic peptide antibodies or anti-citrullinated peptide antibodies, which are more specific than RF to diagnose the RA. But ultimately RA is diagnosed based on the criteria, based on this criteria, based on the scoring of this criteria. Then X-ray shows the periarticular osteopenia, the bone becomes less calcific, then osteopenia develops, soft tissue swellings because of the inflammation, bone erosions, cartilage destructions, joint space narrowing because the cartilage is destroyed, so the bones are more close to each other. When synovial fluid examination, we take the synovial fluid and there will be raised leukocytes in them, right? And MRI scan, the MRI scans also shows us the joint deformities. Then summary. So RA is an autoimmune disease. It is basically an arthritis which is an autoimmune. So it is an autoimmune arthritis, right? It is a peripheral symmetric polyarthritis. Symmetric means if right finger is involved, then left finger is also involved. It is always symmetric most of the times. 99% of the time it is symmetric. Peripheral means it is not in the axial skeleton but in the peripheral skeleton, right? And the most important joints are the hand joints. MCP and PIP are mostly involved, right? Ultimately it leads to the joint damage and physical disabilities. The synovitis is the main pathology. Apart from synovial membrane inflammation, the cartilage destruction and the bone destruction is also the main pathology. Then we have the circulating antibodies. Rheumatoid factor is the most easy test to detect these antibodies. Rheumatoid factor antibodies, IgM category, are the antibodies which are present in 70% of the patients. Morning stiffness greater than 1 hour gives a serious indication of rheumatoid arthritis, and the diagnosis is made by the ACR criteria only when the score is greater than 6. So keep studying and stay relaxed.